on my side, we deliver a lot of systemic therapies, but on your side, your group and your practice deliver a lot of liver-directed therapies. And just, if you could provide us with a brief overview of transarterial chemoembolization or TACE, as well as radioembolization or TARE, and how we use these to treat hepatocellular carcinoma.
So TACE has been around for quite some time. The first TACE, as I recently learned, was performed back in 1974, way earlier than I thought it had been on the scene. And the early RCTs around TACE were performed by Lieu and Lovett back in 2002, came out simultaneously, and these were both trials that were set up with TACE against best supportive care. And showed that TACE did in fact improve survival for patients with unresectable HCC. TACE has been done a lot of different ways over the years. Doxorubicin, cisplatin, and mitomycin C were the original cocktail that was used for conventional TACE. Other agents have been described, such as miraplatin and epirubicin, but in the United States, doxorubicin is largely used in monotherapy now. So as we evaluate TACE literature, it's important to know that TACE is done a lot of different ways, and it's a heterogeneous group of data. I will say that the efficacy of the chemotherapy part of chemoembolization has been questioned. And Karen Brown did a nice randomized controlled trial of 101 patients back in 2016 that showed that there was no difference between patients treated with drug-eluting bead chemoembolization with doxorubicin compared to transarterial embolization alone. And so the mechanism of action is thought to be largely centered around an ischemic effect produced by the beads themselves. And so I think that's important to keep in mind. There are a few different ways to do TACE. There's conventional TACE, which is done by micellizing our chemotherapeutic agent into an oil, and that oil is lepiodol. It's derived from poppy seeds. The other flavor of TACE is drug-eluting bead TACE, and the drug-eluting bead TACE, the chemotherapeutic is loaded into a microsphere, a calibrated microsphere that's then carried to the terminal arteriole and then elutes the chemotherapeutic agent over time. The Precision 5 trial was done back in the mid-2000s and showed that there was no significant difference between conventional TACE and TACE performed with drug-eluting beads. And so in many centers, particularly in the community, drug-eluting beads are chosen for their convenience. And lately, there are two other forms of TACE that have come onto the market, and that is largely around how the chemotherapeutic is delivered. And those are TACE performed with microballoon catheters, or B-TACE, balloon TACE. And then pressure-enabled TACE using a valved microcatheter. And these techniques allow for either the conventional oil emulsion to be driven deeper into the sinusoid and allow for greater passage into the feeding portal veins, or for the drug-eluting microspheres to be driven deeper into the terminal arteriole with greater penetrance and greater embolic ischemic effects. So those are some of the historical and technical advances around TACE here in the recent years.
That's fantastic, Dr. Lindquist, and appreciate that great overview of TACE and even the history behind that, because that is really interesting. It's been around certainly much longer than I realized. One of the things that I've seen recently is a transition a bit from TACE to patients getting more radioembolization, and just kind of wanted to get your thoughts about why we've seen more radioembolization done, and if there's like a patient selection criteria for TACE or transarterial radioembolization, TARE.
Sure. So I do a lot of TARE as a part of my practice, and I think TARE is really emerging as a more effective means of treating these patients if they can tolerate. And when we're doing TARE, it's very important that we keep the end goal in mind. Some of these patients are palliative, and in our palliative population with widespread disease, we have to treat broader swaths of the liver, and sometimes even the entire liver, in order to get a response. And in this palliative population, we want to make sure that we keep the tumor in check, but the radiation has an effect on the background liver. In our unresectable population, many of them already have background liver disease, and so the functional hepatic reserve really comes into play. We need to make sure that we're killing the tumor and not killing the patient in the process. And so in patients that are appropriately selected, that have adequate functional hepatic reserve, we can treat even widespread disease within the liver and get a good favorable benefit. In patients that have more localized disease, we can treat with different intent. So if we have one or two segments that are involved, we can treat with radiation doses that are high enough to achieve an ablative effect, a technique termed radiation segmentectomy, and end up with curative results in many patients. And in patients with early stage disease, recent studies have shown 100% objective response and 85% complete imaging response. So outstanding results with this technique. In patients that are potentially resectable, that don't have enough future liver remnant, we can treat with a technique called radiation lobectomy, where we put higher doses of radiation into a single lobe with intent of controlling the tumor and also inducing hypertrophy of the portion of the liver that's going to be left after a resection. And so this radiation lobectomy technique allows for growth of that liver remnant, control of the tumor, and also allows a biologic test of time so that we know that there's not going to be tumor that springs up in that remnant liver before a patient undergoes a big surgery in order to get the original tumor out.